Okay, well, people are still dropping in and joining us, but I think we can start off so that we make the most of the time we have today with our authors from of the Radically Open DBT Workbook for Eating Disorders. I'll start us off with a bit of an introduction, and then we'll get going. So, thank you all for joining us. We have a mixed audience of clinicians, consumers, also from all over the world. And we're very excited to get started. We have a few housekeeping reminders that I just want to make you aware of before we get to the good part. So first of all, we are recording this webinar, and we will make it available for on-demand viewing for people who are not able to attend live. So automatically your camera and microphone are turned off anyway, but we want to ask you to keep them off during the recording. Now, if you have any questions, you can submit them using the question and answer pod. You can see that at the bottom of your screen, probably, there's like this Q&A, and we will do our best. I'll be managing the questions and answers in the background. And by the way, I haven't even introduced myself, I'm sorry. My name is Rulie Hempel. I'm so used to doing this, I think everybody knows me. Sorry. Of course not. Okay, so I am actually one of the co-directors of DBT Online and Radically Open, and it's the training and dissemination company that I run together with Thomas Lynch and Erica Smith Lynch. And Thomas Lynch is the treatment developer, and Erica is his wife. So, and the three of us have been doing this for a couple of years now, and our group is getting bigger and bigger. It's really wonderful. Anyway, so sorry. So that's me. And as I said, I'll be in the background managing the question and answers. We may not get to all of them because there are lots of people, but we'll do the best we can. And also, thank you for those who've already sent in questions beforehand. Karyn, Mima, and Ellen have been able to look at those, and they will come back to them during the meeting. We also have live transcription available if you want it. You can also turn it off. You can go to the little dot at the bottom of your screen. It says more, and there you can turn subtitles on or off if you want to. Okay, now the authors. Okay, drum roll. Whoa, we'll start with Karen Hall, PhD. She is certified as a supervisor in RDBT by Thomas Lynch. She's also a licensed psychologist, a certified coach, a certified PE therapist, and a certified DBT therapist. Karen is the owner and director of the Dialectical Behavior Therapy Center in Houston, in Texas, which was actually the first to offer RDBT in Texas. And for over 30 years, Karen has worked with adults and adolescents suffering from complex disorders such as personality disorders, chronic depression, chronic anxiety, and of course, eating disorders, which is what we'll be talking about today. Then, Ellen Astrachan-Fletcher, also PhD, is Regional Clinical Director at the Eating Recovery Center and Pathline Mood and Anxiety Center. She's a lecturer at the Feinberg School of Medicine, Northwestern University, and an associate professor of psychiatry at the UIC. And she's an RDBT senior clinician as well. Wow, very busy. So Ellen has over 30 years of clinical and teaching experience in the field of eating disorders and women's mental health issues. She's a nationally recognized expert in the field of DBT and RDBT. And last but certainly not least, this is Dr. Mima Simic. She is the joint head of the Maudsley Centre for Child and Adolescent Eating Disorders in London, and a consultant a consultant child and adolescent psychiatrist. She is a senior RDBT clinician as well as the senior trainer and supervisor for the Maudsley Family and Multifamily Therapy for Eating Disorders and CBT for Adolescent Self-Harm. And Dr. Simic is an internationally recognized expert in the field of child and adolescent disorders. So 3 authors here have a wealth of experience of treating eating disorders of all kinds, and for both adults and adolescents. And I'm sure this will come back throughout our webinar today. So let's get started. Yay. Okay, so we'll start by explaining the difference between DBT and RDBT. Then all 3, Karyn, Ellen, and Mima will explain how each of them got into RDBT. They will explain how to use the book, and we're going to try some things out because each author will share an exercise from their book, and we'll have some time for question and answers. So I'm going to stop my slides and move into the background, and over to you, Ellen.
Thank you so much, Ruli. Honestly, everybody, I agree. We all should know Ruli. We could not do any of this without her. So thank you for all you do for us and for RO in general. So we're going to just kind of address some of the questions that came to us earlier on. So I am going to share my screen. So one of the questions that we got was about RO-DBT and DBT and what is the difference. And through the process of writing this book, of learning about RO, it's become really pretty evident that if people don't know about RO, they're really confused about what RO is. So we're going to address that. I do want to also let you know, just to kind of set the tone of this webinar, that Mima, Karyn, Ruli, and I are very close. We, work together, especially the labor of love of this book. We have a very playful, fun relationship. And in spite
of the fact that we spent a year going over each other's words one by one, right? I mean,
exactly.
We got through that.
We did get through it, in spite of the fact that we have very different biotemperamental traits. And we could really tease each other about that. So one of the things I want to make everyone aware of is that we will be interrupting each other, especially with Mima's, attention deficit issues. She just jumps in and takes over. I'm under controlled, so it's all about me all the time anyway. One of the things. I'm
over-controlled, and I want you guys to get it right.
Exactly. Right.
And I'm going to refrain. I'm going to practice refraining.
So I want people to be aware we are not offended. We actually have asked each other to jump in. So you'll see that free flow as we go through. So getting back to the initial question about differences between DBT and RO-DBT, I've heard people say, oh, RO-DBT is just a branch of DBT. It actually isn't. And I think it can help us understand more by viewing them as dialectics. So DBT is kind of the dialectic of RO and vice versa. So one thing we, just to kind of set the tone, we're looking at transdiagnostic approaches, which basically means these are approaches that look at biotemperament and what underlies multiple diagnoses. So RO-DBT was not developed for a particular diagnosis. So what do we mean when we talk about biotemperament? It's that biological basis of emotion that impacts 2 things: how we perceive the world. So what is that? It's kind of like if one day I'm walking, in the hallway and I pass someone, a colleague that I generally smile at, say hello. And one day I pass them and they have this look on their face, if you can see my face. So the question is, what's my first thought? Is it, oh my gosh, what did I do? You know, is she mad at me? Oh my gosh, I must have done something wrong. There must be something wrong. That's kind of a higher threat sensitive biotemperament. Whereas someone else might go, I wonder what's wrong with Ellen. It looks like she's having a bad day, which is a little lower threat sensitive. So that's kind of how do we perceive the world and the impact on how we regulate our emotions. So DBT was developed for issues of emotional under control. So when someone kind of shares their emotions and expresses and all of that, RODBT was developed for issues of emotional over control for people who tend to kind of hold it in, control and contain. Although sometimes there are bursts of emotional leakage, so don't let emotions confuse you. So we can talk about that more as well. So when we're talking about the core problem that both address, and by the way, I do want to reference this information that I'm going over comes from a worksheet that Ruli is actually going to post to the chat, which talks about the comparisons between DBT and RODBT. We're just covering some very few highlights, but it's really extensive and it's very informative. So I encourage you to check that out. So when it comes to core problems, we have RODBT, which is emotional loneliness, and that's due to social signaling deficits, low openness, and aloofness in style of relating. Whereas DBT, very differently, is more about emotional dysregulation and poor impulse control. And so what people need to learn in these two treatments is significantly different. In fact, it's kind of the opposite. So the emphasis in therapy for radically open DBT is radical openness, not radical acceptance. So radical openness is actively seeking the things one wants to avoid in order to learn. It's challenging our perceptions of reality, modeling humility and a willingness to learn in order to grow. In other words, we recognize that we don't see things as they are, we see things as we are, meaning our perceptions, our experience of the world, our biotemperament, our, all of that impacts what we see and what we experience in the world. Whereas DBT focuses on radical acceptance, and that's letting go of fighting reality. So the way Marsha Linehan describes it, it is the way to turn suffering that cannot be tolerated into pain that can be tolerated. Again, very different main emphasis in the treatments. Also, RODBT emphasizes our need for social connectedness, recognizing that human beings are tribal by nature, meaning we need our group, we need our community, we need to belong. And when we don't, when we get pushed out of a group or when we don't even get accepted in, we suffer greatly from emotional loneliness. And RO also prioritizes interventions designed to take temperament into account, recognizing high threat sensitivity, low reward sensitivity has an impact in how we relate to the world. Whereas DBT emphasizes internal emotion regulation and non-mood dependent actions. So I'll stop there and ask Mima and Karyn if you have anything else before we kind of move on to the next related question.
So I wanted to add one thing, or is it two? I'll have to count. Anyway, one of the things that I just wanted to point out is sometimes it can be very confusing about over control versus under control, because both of them have a high threat sensitivity if the under control person has BPD, borderline personality disorder, so that there can be a high threat sensitivity in both of those then. But the keys, which you pointed out, is that for people who are under control, they're driven by their emotions. They act on their emotions. The emotions control them. And the over control person in threat goes more into control and really dislikes uncertainty. And the other thing, and I bring it up because I struggled with it so much, And Ellen, I don't know if you guys did or not, but when I first started doing RO-DBT, I kept the stance of a DBT therapist, which was very much in educating and telling and work, this is what you do here. This is how you control this. Did you see this led to this? And RO has a very different stance, a much more of a guide, a much more of an ask, don't tell. So I just wanted to add those things.
Yeah, thank you. Really helpful. And me struggle with ask, don't tell. Come on.
I wasn't going to say anything else.
Mima, do you have any thoughts?
I just want to say, I think that's the biggest difference about asking, not telling, and allowing space for reflection, which is very different. And also what is very different is that RO is focused on social signaling, on facial expression, and introduces so many skills that help people monitor their facial expression, their body posture, and how that impacts the relationship with others.
Yeah. Thank you.
And I just want to say, after the COVID period, now the research has shown that we have to go out, we have to connect with people, because the rate of eating disorder, the rate of depression, the rate of working memory impairments and cognitive impairments are the result of our isolation and being lonely, and that we are the creatures of attachment. We need other people in order to feel okay with ourselves.
Yeah, and that's actually a wonderful point, Mima, because certainly over the past couple of years, especially when clients are much more on the side of over-controlled, one of the things I've noticed is the initial relief in not having to have the social pressure or the pressure to be social, but then the huge crash because we just can't survive alone. So thanks for that point. So now I'm putting up this slide to address a question actually we got this morning. And guys, I can't remember what the question is and I can't move. So do one of you remember what the question was?
They were asking how our workbook applied to both over-controlled and under-controlled temperament.
Oh, right. So to someone who has both tendencies. And that's right. So we thought it would be helpful to pull up this slide to kind of highlight, and we do have an assessment chapter in our workbook. So I would definitely encourage someone who's asking a question like that to check out the assessment chapter. Because basically, in general, in this theory, a person tends to lean more towards being over-controlled or leans more towards being under-controlled. And so it's not as common that you see traits in a person where they're both over-controlled and under-controlled. There's typically a stronger leaning. So for example, I'm emotionally under-controlled. Sometimes in some areas, like loading my dishwasher, there is a right way. And I don't understand why no one in my family gets it. It is not rocket science. And so I really feel that way. That's a little kind of over-controlled trait. And I still am definitely under-controlled emotionally. So that's kind of how we look at it is, there's this flexible range where you see optimal control here, where we still lean one way or the other, OC or UC, but we have that flexibility to kind of pull on traits from other sides. And the general idea is we don't flip. So a person doesn't go from being over-controlled to under-controlled or vice versa. But where we are on our side of the bell curve can change. So if you met me in my 20s, as you heard, most of us, I think Mima probably also has around 30 years of experience. Karyn and I outed ourselves about that. So, if you met me in my 20s, you probably would have thought that person is so out of control, under-controlled, she will never have a serious career. And over the past 20, 30 years, I have moved much more towards the middle of my side of the bell curve. Do you guys have anything to add to all that?
I just want to add, let's out myself. Actually, I have nearly 40 years of experience. And yes, I think we move. We definitely move. And we can have some traits. I'm very impulsive still, but I can be quite over control. And there are areas where I can be perfectionistic. And then I was actually a really shy child. I didn't express much emotion. So definitely, I'm very different to the child I was many years ago.
So I will say that self-identification is extremely hard. For the longest time, even when I first started learning RODBT, I was sure that I was UC. And I have a dramatic flair about me, but that comes from being in drama in high school, I think. And I sort of looked at that as being under control. And it was also that I looked at myself as being under control because actually my family was so much more over control than me. So my view of myself was that it's absolutely normal to study for hours at a time. My view of myself is it's absolutely normal to be worried when 1 point off of something, and to have these sort of rigid rules about things. It took really learning that I didn't know that was over control. It was just my life. And so it took me a while. So sometimes self-identification is pretty hard because you don't know what you don't know.
Okay. And now I think is the time we're transitioning into talking about why we entered the world of RODBT. Is that right? Okay. Yeah. So I'm going to go first because, again, I'm UC. It's all about me. And also I volunteered. So how did I get into RODBT? Well, I was really, really hyper-focused on DBT for a very long time in my career. It was very helpful for many of my clients, especially working with, all different types, depression, bulimia, different struggles that really involve non-suicidal self-injury, this real emotional component. And there were still so many clients I just struggled to reach. And, did my best and felt walls up, didn't really know how to get through. And one day, a friend and colleague of mine, Laura Efland, ended up telling me about this new article that came out on RODBT and anorexia. And I was like, ooh, that sounds so, I don't know, novel and exciting. And I'm UC, so I love novel things. So I read it and I was hooked. That was it for me. So I signed up for the first training I could do. That was in California. And I went there with a group of people from Eating Recovery Center, from my job. And I was like, this is it. This is what I've been missing in my ability to help so many clients. And I brought RO back, and I have to say, we started running skills class, and I started hearing client after client after client, and it still gives me chills to think about, who would say, Ellen, I've been getting treatment for an eating disorder. I've struggled with an eating disorder for 5 years, 10 years, 20 years. And this is the first treatment that feels like it gets me, that knows and understands me. And I was in. That was it. And I have to say, it's been an interesting ride being an under-controlled person in this world. Thank goodness Tom Lynch, who is the developer of the treatment, is also under controlled, because otherwise I might have thought, what am I doing here and how do I fit in? And I I'm just blessed to be around all the wonderful people on the senior clinician team. And they've embraced my UC-ness and they tease me like crazy. And I love it because it's still about me when that's happening. So now I will turn it over to Karyn.
All right, Ellen, you stole everything I wanted to say. So just rewind what Ellen said. I think maybe that's the experience that a lot of us have had, is this desire to help clients. That's how I got into DBT. I had this huge desire to help clients that I didn't have an idea about how to help. I wasn't reaching them. And then after I was doing DBT, we got a reputation for people referring to us for complex disorders. There were people coming in that we did not know how to help. And we weren't reaching. So I went to an APA conference in DC, and Tom was speaking, and I went to hear him speak. And it was, I know how to reach these people now. I know how to help a group of clients that I didn't know how to help before. And it was, a light just went off. And I wanted all those clients that had been OC. I just wished I could go back and bring them back in so that I could redo. And so then I made a decision just like you. I have to learn RODBT. And I love to learn anyway. I don't know if I said that yet or not, but I love to learn. And so that was right up my alley. And so then it was, yes, I'm going to learn as much as I can about RODBT. What about you, Mima?
RO came in my life when I was co-leading the Moses Center for Children's Eating Disorder, but I was also consultant psychiatrist for DBT team, for our adolescent DBT team. And together with me across the two services was our consultant psychologist. And we just developed a day program. We put DBT into our day program, and we felt something is missing. And there was advertisement for one day with Tom in London. It was 2014. And the two of us went. And honestly, after day, I just approached Tom and Eric and said, guys, you have to come and train us. We have our own models, they're working, but there is a missing link. And RO was definitely something that was a missing link. And there is a question that we got is, what to do with the clients who are under DBT but are over control. And I just want to say from our experience, when we were running a DBT service, we started assessing clients who were coming to DBT service for over control and under control. And actually, over control clients then got RODBT. So for years, we were running transdiagnostic groups between eating disorders and clients who were highly suicidal using our model if we identified over control. And it's the same, I'm kind of repeating Ellen, it is that young people in our day program and young people in our outpatient eating disorder service, they're saying, this is the first treatment. And those are young people who had CBT, they all had experience with family therapy that routinely is delivered in our service. And then they will say, this is the first treatment that speaks to me. Yesterday, I was taking somebody in treatment individually, and I explained over control to the kid, and kid said, well, that's me. I'm coming to treatment. So maybe this is a right moment for us to kind of think about who did we write the book for? And where I want to start, and please guys, do chip in. It was fun writing, but it was fun writing for the population that we thought not everyone has access to treatment. And we created this book as a self-help book because we know from all the epidemiology that probably only 1 in 5 people get treatment for eating disorder. And there is never going to be probably enough therapists or not everyone will access treatment. So this book was something that we thought we should share with people because they may find it beneficial and helpful. Use it as a self-help book. Use it as a self-help book to improve your relationship, because there's a notion if you are less lonely, or if you develop close relationship, that will help your eating disorder symptoms. There is also research now showing that better outcomes in treatment in eating disorders are if people express their emotions during treatment. So very crucial, it does improve. But this book was done to be widely available with the aim that hopefully it's going to be helpful for people, but people still have to have their little team. We want everyone to be medically safe. So we are asking people in the book that they create their team. It can be a medic, it can be a nutritionist, to help them to be physically safe, but they also can use this book to improve their relationships. Or they can use with the therapist when they work chapter by chapter with the therapist and give themselves time to practice the skills. There are a lot of skills that we included in this book that we would like people to practice. Anything that you want to add, guys?
Yeah, I would add, thank you, Mima, that was really helpful. I would add, it's also because we recognize that Radically Open DBT is truly like no other treatment. People often think, well, if I know DBT, I'll be great at RO. In fact, it's the opposite. I can't tell you how often my DBT knowledge has gotten in my way of doing RO effectively. In fact, my supervisor has said, leave your DBT hat at the door. When you're in here, it's a very different, process. And in supervision, I've heard, that was a great DBT intervention, not at all RO, but great if you're doing DBT. So another reason that, we hope this book will be helpful is that while we encourage, I can only speak for myself, encourage everybody to get trained in RO because it is like no other treatment and it does reach people previously you might not know how to reach. We recognize that the training takes time and we recognize that there are not enough RO trained therapists. So it can be helpful at least to use the workbook in treatment. I'll say not if you're not trained, but while you're getting trained, because I want to kind of smuggle, go for it. And while you're doing that, this workbook can really be a wonderful adjunct to therapy. So just wanted to add that piece.
I'd like to add that RO-DBT is a transdiagnostic treatment. And so while we're talking about a workbook, RO-DBT workbook for eating disorders, what we basically did was give eating disorder examples because the RO treatment is the RO treatment. So there's not a separate training. Here's RO-DBT for eating disorders. RO-DBT treats the underlying temperament that can result in different disorders. So it's primarily, the nutritionist and the physician who are on the team, that might be different than for other disorders, but the actual RO is the same. Did I say that clearly, guys? Does that make sense?
Oh, yeah, absolutely.
Okay. Are there any questions really? Is there anything that we want to address at this point of time? There's a question about, do presenters think RO as don't tell is because in other DBT clients, they're needing more structure approach versus RO where clients are rigid with structure? It's an interesting question.
Who wants to jump in?
Can you repeat the question?
Okay, is that the being more reflective, as don't tell, is that because DBT clients are needing more structure. So in DBT, you're introducing structure all the time.
Mm-hmm.
And in RO, where the clients are quite rigid with structure, you introduce this you introduce the stance as don't tell.
Oh boy, that's a complicated question. I think there are many, many different answers. I mean, one of them for me is that the person who is over-controlled, they're often not giving you a lot of information. They have inhibited emotional expression. They're not giving you a lot of information about what they're thinking and feeling. And so if you assume something and start giving information or giving an intervention, it can easily be that you're way off track because you didn't really get what's going on with that person. So the more we ask, the more that they get information they give us, more we draw out, and the more they apply it to themselves so that it is more relevant to them. For the under control person, they're sort of out there. They give you the information so that you take to use for problem solving. I think also, I mean, am I saying this right? But the over control person sometimes doesn't like to be told what to do, and so sometimes the ask, don't tell is much more effective in creating a collaborative relationship with the client. What would you guys add?
I think that kind of giving the space and giving the stance, that is a different stance. I would think that OC client, if they have a very instructive therapist, would find it patronizing and probably will withdraw more, and having asked them tell, they're heard, and also entice them into starting to express. They start to learn to identify emotional states, or maybe they have identified, but they have not learned to verbalize them, and they have not learned to be vulnerable. And that's what our opens. Being vulnerable with a therapist that feel that the therapist is safe.
And I think the ask, don't tell works well with the client who comes in and doesn't talk to you kind of at all. It's like you're sitting there saying, what are we working on? And so if you try to jump in, you're very likely to not even hit issues that are relevant. So it works really well in terms of pulling them out, getting them used, as you were saying, Mima, getting them used to expressing themselves, versus the therapist sort of taking charge.
Yeah. And I would also add, that sometimes we're wrong, right? And it would be, one of the things I remember Tom saying early on is it would be arrogant of me to assume that I know. And when we tell clients things, whether it's about themselves or what we believe is in their best interest or anything, I'm bringing my stuff into that. And that's not necessarily going to help the client. Also, I've noticed there are often when I tell and don't ask, which, trust me, I've worked very, very hard on. When I do that, one of the things that I've noticed is a group of OC clients might respond by saying, you don't know me, that's ridiculous, you don't know what you're talking about. Even if, by the way, I might be kind of correct. There's a lot of like, absolutely not, what are you saying about me? But sometimes there's another group of clients who might be like, yeah, you're right. Yeah, you're right. Absolutely. And I think, oh, I'm on a groove and I'm headed in the right direction. And then they don't come back to treatment. And it's because I wasn't right, but they didn't want to let me know I wasn't right. So when you ask instead of tell, you don't fall into either of those traps.
I just want to ask you something very practical. Do you hear lots of kids playing and having fun? Because I'm having a lot of kids playing in front. Is that impacting my sound? Okay. I just wanted to check with you guys. And I do think, because I can see the questions just before we move to the next one, and I think it belongs here. Maybe if we can explain what we when we say underlying temperament that applies to our DBT, what do we mean by that? There is one question, and maybe this is a right moment to just summarize what are the bases of overcontrol regarding the temperament, and what personality traits, what temperamental traits are the part of overcontrol.
Well, I mean, in general, and again, you know, I'll take a first stab at it, you know, and Karyn and Mima jump in. In general, and again, as we talked about before, like high threat sensitivity, while that's typically often seen in over control, you can also see that in under controlled people. So it's not black and white. But in general, when someone is more over controlled, they tend to have higher threat sensitivity, meaning they're more likely to perceive threat in the world. They tend to have low reward sensitivity. And this is probably one of the greatest differences I see between myself and a lot of my beloved OC colleagues. Which is I get super excited about silly things. You know, I am relentlessly made fun of for my case, which is all these sparkly, you know, loving, wonderful things.
Pink. Lots of pink.
And you know, so I have high reward sensitivity, whereas when someone's more emotionally over controlled, they tend to have low reward sensitivity, which means it takes a lot of reward to feel rewarded, to get excited. So they're not easily impressed. And I am easily impressed by all kinds of things. So, you know, that's one thing. Detail focus. When people are emotionally over controlled, they tend to be highly detail focused, which means they see details everywhere, which means they see mistakes everywhere. Whereas when people are more over controlled, they tend to, again, not hardcore black and white rules, but tend to be more globally focused in our processing. So the way that I sometimes describe it to clients is an OC will see every vein on every leaf, on every tree. I run like smack into that tree because I'm looking at the beautiful forest. I don't even see the tree until it's in my face, right? So in novelty seeking, when people are more over controlled, they don't like new experiences. They like to know where they're going to go, what's expected of them, all of that. Whereas people who are more emotionally under controlled, like love new experiences and novel things. And inhibitory control. So in general, when people are more emotionally over controlled, they don't just have good inhibitory control. They have superior inhibitory control, right? It is off the charts, meaning if I don't want to respond to an urge, I don't have to. But that doesn't mean they don't have urges, and it doesn't mean they don't respond to their urges. But if I choose not to, I won't. Whereas someone who's more under controlled, boy, we have urges and we're acting on them before we even become aware of it, right? So those types of things. I'm missing a few, but I don't want to hog the stage.
I just want to say something about nurture of usually over control. Over control people are usually nurtured in an environment where achievement is important. And when people are perceived, I just did an example yesterday that working with the family and the father said, she can't express, vulnerable is not good. If you're vulnerable, that means if you express vulnerability, you are not good enough. And those are sometimes beliefs that influence that expressing emotion or expressing being vulnerable in somehow is a deficiency. So that's what I see as the part of nurture of over control and temperament that families unintentionally lead to coping styles, which is I'm not going to express my vulnerability. I'm not going to make mistakes. Making mistakes is wrong. I'm going to inhibit expressing my emotions. I have to appear strong.
So I can remember Tom saying that over control people don't need to work harder and do more. And so over control people tend to really follow obligations. They do what's needed to be done. They sometimes, but they have a lot of trouble relaxing and chilling out and being playful. And of course, that's the way a lot of relationships are formed. So I would just throw that one in there.
And they plan their day, and they want their day to go according to the plan. They get very frustrated and anxious if it's not going kind of their way. They want to feel that they're control, and they do not tolerate very well uncertainty. That's one of the issues that is really hard for them, and that kind of brings the need for control even higher. It increases the need for control.
I can just see a couple of questions coming in, but I'm wondering, some of them are very therapy focused, and of course we are here, the workbook is for everybody. So I'm kind of just thinking maybe we can keep these till the end. I just want to let everybody know we are seeing them. I think it's better to keep them to the end and let you guys continue, and then hopefully we'll have some time to answer those.
Okay.
Yeah.
Thanks, Aurelie. So maybe where we can move, and that kind of answers a bit of the question about who is this book for, and can it be used outside of eating disorders? It's to give examples of some of our chapters. So where I think I want to start, and it was when we were selecting this, it was like, what is our favorite chapter? What is the chapter that we liked and we like reading, or what was fun about making this chapter? And where I want to start, and I will hopefully share my slide, is with the chapter 5. And chapter 5 is really about our neurobiology. I'm very much into talking about neurobiology lately. But most importantly, it is about how our biology affects us and how our biology affects our relationship. And we are all born with the same neurobiology. We are all born with the same links between our brain and with our body. And those links between the brain and the body, they make a brain-body networks. And why is that important? Because for all of us, it's so important to know if you're living and we are surrounded in the world where we can be safe, or there is a danger around us. So human brains scan the environment all the time because they have to determine how they're going to respond to the environment. And environment is not just what is outside of us. Environment is also sensations of our body, our thoughts, our feelings. And what nature has constructed is that we have inbuilt, preset brain-body networks that are going to respond automatically if our brain appraises the certain cue is coming. And I want to thank for this image to Ellen's brother. He was very helpful. So we did have support from our family when we were writing this book. But what this image shows is when the cue comes, and as I'm saying, cue can be from outside, cue can be inside of our body. When the cue comes, our brain appraises what kind of cue it is. And depending on what cue the brain decides it is, it sends signals, and the signals from the part of the brain that is amygdala, which is deeper in the brain, the signals go up to the surface, to the cortex of the brain, and they go down to the body, to autonomic nervous system. The upward is much slower than autonomic nervous system. So it takes 4 seconds for us to start responding to the facial expression, and it takes brain 20 minutes to actually be able to label and identify the facial expression on the other person. Our autonomic nervous system influences our respiration, our heart rate, our muscles, our pupils. And all of that is because we have to decide, is it time to run, fight, or it is safe for us? Overall, we can identify 5 cues that will trigger 5 emotional states that are very different. And each of these 5 emotional states have the brain-body network that is going to be dominantly parasympathetic, which is we can relax and rest, or it's going to be sympathetic, which is let's prepare our respiration, our heart, our muscles to either fight or flight. Where we think that people with eating disorders are, and that's where it becomes relevant, and that what has been explored in this book, that we see that people with an eating disorder who are OC anyway are very sensitive to threat. But on the top of that, eating disorder very much occasionally go in between threat state and overwhelm state. It's like a seesaw going threat, overwhelm state. And overwhelm state, if you see, it has certain body expression, and the body expression, how the body feels. Body feels numb. Our emotions also feel numb. We feel frozen, detached, disconnected, vacant. The urge is to give up or to faint. And the facial expression is inexpressive, slow body movements. The voice is monotone. It's a vacant stare. And the facial expression, when we are in threat state or we are in the overwhelmed state, will impact our social relationship, because other people respond to the emotional state that they see, and they see emotional state that we are in through our facial expression. And facial expression, lack of facial expression is a facial expression. And if you have a lack of facial expression, that signals other people that the person is in a threat state or in overwhelmed state, and they feel that they cannot feel safe with the person who is in the threat state. They have, our threat state is a threat signal for the others also. So what we have in the book is a little practice exercises that are there for people to practice, to identify different cues, but also to identify their responses, how their body feels, and also how their facial expression is. And these are the faces that are in the book. And if you just look at each face, or if you look at the food cues, I will leave to you what kind of emotional state that evokes in you. Where the eating disorders are, it's often that food by itself becomes a threat cue that will provoke certain reactions. And at the end of the day, we know the cues, we can identify the emotional state, but most importantly, we can change our physiology. And if we can change our physiology, we can change our emotional state, and we can activate the social safety. So I will finish with asking all of you, but I can only see Karen and Ellen, if you can please sit up in your chair and then lean back, lean into that chair, relax into your chair. And now take a deep, slow breath. And then exhale slowly, send that diaphragm. And now, please, can you do a closed mouth smile? So move upwards, the edge of your mouth. Check that there is a little bit of narrowing of the eyes. And now do all for me, the eyebrow wag. And this is all to send your brain the signal. If I'm in that state, I must be safe, and I might be activating my social safety. Thank you. Thank you, guys.
Thank you, Mima. Oh, go ahead.
Do you want Ellen to show your chapter? I'll stop sharing.
Okay. And I will start sharing. Thank you. By the way, while I'm pulling this up, just want to point out, we did talk about, we did talk about what chapters were we going to speak to. And we said, oh, pick a favorite chapter. And I want to throw out there that I said, are they going to be chapters that we wrote the initial draft on, or picking any chapter? The consensus was we would do a chapter that we actually were the initial author of, because I might have chosen the chapter Mima just reviewed, because I love that chapter. But this is one that I worked on initially. So it's chapter 10, social engagement. By the way, one of my favorite things about this chapter is the title, because we went around and around about how playful we wanted to be. And in fact, we were questioned by the editors about the playfulness of the title. And Mima, Karyn, and I kind of said, we want to be playful. We're keeping the playful title. And so we did. So social engagement, we aren't talking marriage, just connection. Whoops, we don't want to scare you. So one of the first things that I address, or we address in this chapter, is, basically ways that we don't show up in relationships and how that can negatively impact our ability to connect with other people. It's hard to connect with someone who's not there, right? So going absent or ghosting. And one of the things that I really enjoyed about including this piece is that because it's going absent, people often don't view this as a behavior, because they view it more as like a lack of behavior. And in fact, it is a powerful social signal. So when we talk about ghosting, it's not responding to emails, not responding to texts, not responding to phone calls. And it becomes one of those things, and I, hear this time and time again. I didn't call them back yet. Now it feels like it's gotten too late. Now I don't even know what to say when I call back, because it's been a week and I'm too embarrassed to go over all the reasons why I didn't respond initially. So that kind of going absent or ghosting continues, and it just gets worse and worse and worse. And one of the things that we need to consider is, how many times can you refuse or not respond to an invitation before those invitations stop coming, right? And so it kind of highlights that we, even sometimes when it can feel so hard, right? Like, especially when you have some anxiety about social interaction, or, really using what Mima just went over to engage your social safety system so that you can go out and be social. Because again, connection won't happen if you don't show up. So just give some thoughts to, how often do you respond? How often do you not respond? And I do want to say, one of the favorite parts of the book for me was writing the stories. And our stories are so informed by our direct client experiences. So I know, for example, some of the clients that I've worked with in the past might recognize some of the things that they've talked about in some of these stories, because they're real and they have a really powerful impact. And then the next section that we go over in this is deception or lies, right? And we often don't want to think about lying, especially if being honest is a value of ours. And all human beings lie. And if you tell yourself you don't lie, you're lying to yourself. And that's something that we have to be aware of, because lying doesn't make us a horrible human being. it makes us a human being, and we need to be aware of it. And we need to be aware of both positive and negative consequences. So we often think lies help us get out of trouble or get us something that we want. But more often than not, lies or deception push people away, and it makes us feel more alone. And especially when it's not connected to our values. And that can kind of contribute to that belief that often when people are, lean towards being over-controlled, I've been bad, so I deserve to be punished. And so it actually contributes to that cycle that keeps people stuck. And then, one of my favorite things to talk about and to play with is indirect communication. And we refer to indirect communication, very specific types called disguise demands. And disguise demands, everybody uses them, whether you're over-controlled or under-controlled. Trust me, I've had plenty of experiences with disguise demands as well. And it's really wonderful to see it kind of come to light, because we're often not aware of how we are expressing these disguised demands. And they do really interfere in our ability to connect with people. So I thought it would be really helpful to get a little demonstration going on some of these disguised demands. And so Mima, I was hoping maybe you could help me demonstrate a pushback. You're muted. So
what do you want me to do?
Well, we kind of talked about it earlier that you would help me demonstrate a pushback so that the audience...
Honestly, what came after you? Where is this coming from?
Well, I just thought it would be so helpful for everybody to see a pushback in action.
Ellen, I really think you have a problem. Why don't you reconsider on her? Why don't you reconsider what you're doing?
Okay, point made. I hear you loud and clear. So for whatever reason, maybe Mima doesn't want to help me today. Karyn, maybe perhaps you could help me demonstrate a don't hurt me.
Oh, wow. Thanks for asking. But you know what? You're under control. You're so much better at demonstrating things than I am. How about if you...
I appreciate that. Certainly being UC helps. And I just think it would help really bring it to light. Karyn, if you could just help me demonstrate that don't hurt me.
Well, Ellen, I really do try hard to help you out when you ask. But I don't know. I just don't feel so I just don't think I can help you today.
I appreciate it. I know it's tiring, and we've put a lot of work into this. Just really one more time. Do you think maybe you could help me demonstrate a don't hurt me?
Oh, Ellen, I just got a headache, and if you really cared about me, you would understand I just can't do what you want. It's just too much. If you were really my friend, you would know this already.
You're right. So I'm going to back off. No, I'm not. Yay. So thank you, Mima and Karyn, for your wonderful acting abilities. Trust me, they have never given real pushbacks or don't hurt me's. Maybe every once in a while. As Mima beautifully demonstrated a pushback, I'm not telling you what to do, but you better do what I want. In other words, back off, Ellen. I'm not helping you today. And don't hurt me's, as Karyn beautifully demonstrated, you don't understand me or you are hurting me. And if you cared about me, you would stop. And it's funny because I even noticed, Karyn, you were acting that out so well that I wanted to start treating you fragilely. And it's been really helpful for me with pushbacks and don't hurt me's to be able to identify them in treatment and to speak to what they are. Because I can tell you, I unintentionally for years have probably reinforced don't hurt me's. and then ended up likely thinking I was caretaking, but ended up fragilizing people. And it wasn't helpful to them or to the therapy process. And so now, you know, after really understanding this through RO, have a much better grip on it. So with that, I will turn it over to Karyn.
Okay. So I chose the chapter near the end, and it was about enhancing intimacy. And for me, the reason I chose this chapter is I think this is where RO is headed, about connection with other people and about really making connections with other people. And I also think, just to out myself, that I learned a lot about really, truly connecting and being vulnerable with people through RO. I've learned a lot myself. So the problem, as probably all of you know, is there's an epidemic of loneliness. And for some people, when therapists give social skills or give groups to join, they can make the connections, they can start to alleviate some of their loneliness. But for people who are over-controlled, that's not the case. And in fact, people who are over-controlled have often tried for years to make connections, but they do it through being useful, working hard, sacrificing for others, doing the obligated thing, doing the right thing, going by the rules, being super polite. I myself was very nice and I still am, but it was really about trying to connect through if I'm nice enough and kind enough, kind in a more general sense, about just being compassionate is a better word, then people will like me. But it turns out that's not the case. That really connecting with people comes from being vulnerable and opening up and sharing who you are and letting them know who you are. And also through other skills too. So the problem for people who are over-controlled is they are often very confused. I did all these things. I work hard. I contribute. Why am I not connected? Sometimes they don't even know they're not connected. I've had some people say, I have close relationships. And then they go through RO and they said, I didn't know what close relationships were. And what gets in the way is what Mima talked about. When you're in threat, you can't truly connect with other people. And a lot of people who are OC go into threat when they're around people. They may be doing social comparisons. They may be seeing it as, there may be envy. There may be, this person it's a competition. Or am I just good enough? It's constant evaluation. Or am I doing the right thing? So they go into threat when they're around people, and that means they can't connect. They also are often, OC people tend to be very serious. And you know what? One of the things I learned is that one of the key ways that you connect with people is through teasing. I've tried to show some of that playfulness and teasing throughout, as my colleagues have, that's one of the ways that people really do develop intimacy and connection, is being able to play with each other. And so when they don't realize that they can do all the social skills, but if they're in threat, that inhibits the way they're expressing themselves. And their social signaling doesn't send, hey, I want to connect. In fact, if they get very flat-faced and because they're scared and they say, how are you? And they can't really offer a lot of information because they're shut down, then the social skills aren't going to work. And so that's where RO comes in and says, hey, let's look at your social signaling. And that makes a huge difference for people who are trying to connect and are very confused about why they've never been able to connect. And there are lots of other reasons, that low reward sensitivity that we talked about. For people who are OC, just being with people, we can put them in a group of people. Just being with people is not necessarily rewarding. It's something they have to learn, but especially it's not rewarding because they go into threat. So we have to teach them how to enjoy being around people and have genuine pleasure. And that's part of what we do in RO and part of what we talk about in the book too. And some of that is to activate social safety, to stop the social comparisons and sort of rule-oriented about how people should behave, how I need to behave, to be able to enjoy non-productive time, to be spontaneous and enjoy novel experiences. And also to truly understand what genuine friendship and intimacy is. Because I think a lot of people who are OC don't really get, what do genuine friends do? What is true kindness? One of the things I get, and so the exercise that I decided to choose was about coping with rejection. Because when I talk with OC clients, one of the things that comes up is this fear of rejection, that they don't want to try to engage with people. They don't want to try to connect. They don't want to practice what we're offering because of this fear of rejection. And RO says, yes, guess what? You're going to get rejected. It's just part of life. Mima's been rejected. Ellen's been rejected. I've been rejected. Ruli's been rejected. And everyone out there has been rejected at some time or other. But RO leans in. Instead of how do you cope, RO, which I shouldn't have titled it that actually. So what RO does is lean in. So coping with rejection is really learning from rejection. Is there something to learn here? First of all, it's normal, happens to everybody. And then is there something to learn? Is there something for me to learn about my social signaling? Is there something to learn about the people I chose to connect with? And then it's to look at, did you lose something? Because sometimes our painful emotions are about something we lost, that maybe we thought this person would be the person we'd grow old with, and we lost that dream for the future. Or maybe we lost the idea that if we offer enough to someone, that they will be our friend. Or something else that we lost. So to really consider what you may have lost and look at those emotions in terms of when a connection doesn't work out. And then remember, what are the undesirable parts of what you might have lost? Because we tend to only focus on what we wanted that we lost by this rejection. And so to look at the undesirable parts. So is this an end, or is it really a change in a direction, or a what's next? And to look at this experience with rejection as, okay, so what's next? Or what do I change? What do I do differently? To remember to not judge yourself harshly, to be kind to yourself as you would to a friend or a child. And it's not exactly that you're making a choice. Like you're not saying, okay, I don't want to feel pain, so I'm not going to reach out. Because you know what? There's pain in seeking out relationships for sure, but there's also pain in not doing so. So this idea about truly experiencing intimacy, learning how rewarding that can be, that's a huge part of where we're headed with RO. And I'm looking at the time, so I think maybe we turn to questions now and see what questions people have for us.
Yeah, okay. One question is, do you think that this workbook could be used by people who struggle with over-control issues that are not ED related? We could just do a yes or a no.
I would say absolutely. I mean, it goes back to being transdiagnostic. Like the principles of the treatment are the principles of the treatment. And we applied it. We used eating disorder examples, but you know what, Ellen and Mima, I remember us talking about it. We used examples that are not eating disordered on purpose so that we would communicate the idea that these principles work with OC regardless of how it expresses itself in terms of a diagnosis.
I think that's a really great point, because there was also a question at one point about using this workbook for binge eating disorder. And what I would say about that is, just like whether it's binge eating disorder or bulimia or anorexia or ARFID or any non-eating disordered issue where over control is the underlying biotemperament that creates some of the struggles that a person's having, you'd use the book the same way, right? Because it's about really working with your over-controlled coping. And the general idea is, as you work with what underlies those other struggles, those struggles start to dissipate.
Thanks. Oh,
Mima, you're muted.
Mic's off.
This is artificial way of trying to refrain myself by muting myself. I just wanted to say regarding ages, that book also, when we were thinking about even including examples, but how we wrote the book is for book to be possible to use, that older adolescents can access the materials. So it does span from adolescence to adult age.
Okay. Yeah, so and I think you just mentioned adolescence because there was a question, the age range for this book, and I've also seen questions in the in advance that people were asking if the book can be used for adolescents and.
Yes, the older adolescent, and I don't know older adolescents, is it culturally same, but anyone who is 15 and over, I can see, and I know that some people in Australia are actually using, the therapists are using this book with young people. And one young person did say that every person with should have this book who has she's with anorexia nervosa. She said every person should have, because the examples, she could relate with the examples. But examples that we have a book are transdiagnostic regarding eating disorder. So we do have different, it's not about a certain eating disorder, it is about temperament and personality that person with eating disorder has.
And there's a question, at what point in treatment can you begin to use the book? Should the patient be medically stable, motivated to change, and not engaging in treatment interfering behaviors?
Can I start? I think in any treatment, the patient should be medically stable. That's prerequisite, and we are very clear, and that it does not mean that very early people cannot access the book. So in our day program, we have very severely ill people at the point that they're just medically stable, and we do run skills classes with them, RO, and they can access that, and they like that. That's our main treatment modality with very severe people, in the context that context is ensuring that they are medically safe and that they're eating. We are talking, and they're regularly eating. I don't know if you want to add, guys, something.
I mean, the one thing I might add to that, because I also work in higher levels of care, and you know, we do tend to get patients who are really struggling quite a bit. And we run skills classes. They're a little bit different than they would be in outpatient, obviously. And for the individual RO, that's something where, you know, I just make it very clear to patients that if they're actively using non-suicidal self-injury, for example, that's something that from an RO perspective, we believe a patient can use their superior inhibitory control not to act on, even if they believe that they should self-injure because they deserve to be punished or whatever. But if they're actively self-injuring in RO, we wouldn't move forward because we have to address the self-injury. So what I say to people is, if you're actively continuing to self-injure, it's just a signal that you're not ready to do the individual RO work. And if you really do believe the individual RO therapy will help you, then use your superior inhibitory control to not act on that. And I've seen that work over and over again. So I absolutely believe we can bring up RO, and if a client is open to it, you know, using the workbook in that setting is a great way to start the work.
Roy, do you want me to answer FBT and RO-DBT question?
Yes, sure. Okay, so the question is, how do we use this in combination with FBT, which is family-based treatment?
Yeah, mostly has family therapy for anorexia nervosa, which is FBT updated, and how we use it is that for people who are over controlled, we use in FBT phase 2, which is FTN phase 3. So in the later stages of treatment, when we are talking about individuation and autonomy, we use for people who can be quite still cognitively ill and not always 100% motivated. We will use and move them to FTN, and then we move FBT more in the background and change the target of treatment from that point.
Thank you. Okay, so I have this is a question that coming quite early on. Mm-hmm. A person who is over-controlled, who is now in standard DBT, what should we do? Should I keep her in DBT or take her out and move her to RO DBT? Or can standard DBT still help her?
Well,
I can.
Go ahead.
No, I can only just kind of say from what we've done in those cases. And I would say, because it's that we will try to assess early. That's kind of one thing. You try to assess at the beginning so that you can have 2 streams from the beginning. If somebody started DBT, it has to be what the person thinks about the treatment. There is a relationship with the therapist. It gets kind of complicated, but sometimes we have finished DBT and then when DBT, a bit of DBT, and then move to our DBT. I don't know what you've done. I don't know, Karyn, what you have done in those cases?
I mean, it's kind of one of the things that we tend to see happening when, people are emotionally over control. They, again, control and contain, but eventually burst into emotional leakage, which can be sometimes extreme emotional expression. By the time people get to higher levels of care, they're often emotionally leaking more often. In my experience, that means sometimes they want DBT to learn to control and contain. But the problem is when someone is emotionally over-controlled, they actually already know how to control and contain really well, but they have bursts. So if they learn to control and contain their bursts, what do you think is going to happen? The bursts actually come more, right? Because the emotions have to get out. So what they actually need to learn is to slowly let it out, to be vulnerable, to turn to people. So in that way, if they continue in DBT, it could teach them to be doing things that actually make their expressions worse for themselves or harder. In a similar fashion, if they have non-suicidal self-injury and they're in DBT and they're getting skills to learn to not act on the urge, but actually their self-injury is not related to their urge, it's related to the belief that they should self-injure. And so what they need to learn to do is very different. But if they remain in DBT, they're just getting skills to not act on the urge, which is something an over-controlled person doesn't need and isn't actually going to help change the behavior. So in that way, it really is important once you identify someone, or more importantly, they self-identify as over-controlled, RO is going to help them with what they struggle with more.
Thank you.
I agree. And I think that one of the things that happens that I worry about is sometimes the OC person is a wonderful student and they will sit through the DBT and they will do the homework and they will participate in the discussions, but nothing's changing. And then they walk away with the idea that therapy didn't help and it doesn't work. And I don't want that to happen for the client. What we do is what we did in the beginning. Now we assess early on, Mima, like you do. But what we were doing when we first learned about RO was we talked with the client. We explained to them the differences between over control and under control and how DBT really focuses on having more control, which is not something someone who has over control needs. And I will have to say that it was so difficult, but we changed, with the client's agreement, we moved them to a different therapist to start the RO, because the relationship was set up in a certain way with the DBT therapist, and it was just too hard to change that dynamic. So that's, we transferred for the client to be able to get RO.
Thank you. I'm aware we have only 3 minutes left, but what about the other way? So there's a question, if someone is under controlled, do you ever get them in your RO DBT program? It seems like the process and skills would be useful for them too.
No, go.
Okay, so for us, sometimes we have people who are under controlled that we use RO as a stage 2, sort of as in DBT a stage 2, to help with relationship skills. That's one of the ways that we use it. Go ahead. Yeah.
I have incorporated work with bulimia nervosa a number of RO skills, the indirect communication, cues. There are a lot of stuff that is transferable and can be useful. And for people who are struggling with relationship, absolutely some skills are brilliant.
And I can speak from personal experience. I, being really under controlled in my 20s, definitely needed to learn from DBT, but I feel like I have learned so much more about myself from RO DBT after I learned to control and contain. And I just feel like I have grown exponentially from RO. So personal experience, yes, a UC can learn.
Thanks. Okay, well, we have 1 minute left, but there's been one question, been on here for quite a while. Do you think that any kind of behavior therapy, but let's stick with RDBT because that's what we're talking about, is useful for those with complex PTSD?
I will answer because we are just now transdiagnostically working eating disorder, complex PTSD. That's our new project that we will run the group together. So, and that is the therapist, RO therapist from RO, and we had complex PTSD in RO.
Okay, thank you. So, we actually gone to the end. I can see there's still a couple more questions in there. I'm happy to stick around for a bit more. But if you guys need to go, obviously.
Shall we thank the audience? Thank everyone for brilliant questions that really made us think, and that's always good.
Right, well, and thank you to Ellen, Mima, Karyn. Thank you so much for sharing your favorite chapters and your experiences and your knowledge, of course. And I'm just sorry that we run out of time because it was really fun doing this. And thank you all of you who've been here to make this webinar come alive with your questions. So thank you very much, and hopefully see you soon sometime.
Thanks, everyone.
Thanks.
Bye.
Bye.